We're going to discuss the medical emergencies we face in casualty. Basically, I'm going to cover the common ones with a more practical approach, not going into details theoretically. So we'll be covering the most common one we encounter in emergency, medicine emergency. So patients presenting to us with dyspnea covers acute pulmonary edema, acute severe asthma. Acute pulmonary edema is defined as abnormal accumulation of fluid in the extravascular compartments of the lung. So the symptoms with which the patient presents to us is rapid onset of dyspnea at rest. He's tachypneic, his pulse rate is more than 100, and he's hypoxic. So on presentation, he will be coming with falling saturation, with tachycardia, with tachypnea. When you examine the patient, there will be crackles and wheezing in the all chest compartments. These are the basically etiology leading to pulmonary edema. Patient having MI, which is leading to left ventricular failure with ventricular septal rupture, a patient with hemorrhage, or post cardiac arrest patients, patient going into myocarditis, that may be because of viral, which is very common these days, or end-stage cardiomyopathy patients, maybe dilated cardiomyopathy, ischemic cardiomyopathy, or patient with HOCM, aortic dissection. These are the basically etiologies leading to pulmonary edema, which we have to keep in mind when the patient presents to us with these symptoms and signs. We have to rule out these etiologies. This is typical chest X-ray of acute pulmonary edema. On finding investigations, the BNP levels are substantially elevated in a patient of pulmonary edema. Echocardiography helps us in ruling out the etiologies. This is the management of pulmonary edema. Basically, when a patient presents to you in casualty, what you have to give to them, give them diuretics and give them oxygen supply. If the patient is hypertensive, that is systolic blood pressure is less than 90, you will not give diuretics. We will start inotropic supports, that is dopamine or noradrenaline. And dobutamine can also be started until unless patient is in arrhythmia. Dobutamine we have to use it cautiously if patient is in arrhythmia. As well as dopamine. Dopamine increases the heart rate. If the patient is already in tachycardia, we have to use NORAD, and NORAD is the inotrope of choice. Now covering acute severe asthma. Patients who are already suffering from asthma will present you to with complaints of there is increase in chest tightness, wheezing, there will be a whistle sound coming out from the nose, patient will be breathless, and patient is not relieved by their usual inhaler they are taking on regular basis. The symptoms will not resolve despite using the inhaler. Then we have to suspect the patient is in acute severe asthma. What we have to do when the patient presents to us in casualty with breathlessness, with history of asthma, what will be the signs most common and sign is patient is tachycardic. There is patient is unable to speak and he's not able to even lie supine. He's too tachypneic. And rarely we see a sign pulsus paradoxus. And these pyrometric values and pulmonary function tests are not advisable at that time, but they are helpful if the patient is once settled. When we have to make a diagnosis when we're not clear about asthma. And one of the most important investigation is ABG, arterial blood gas analysis. That help us in telling the level of carbon dioxide and oxygen. If there is associated increase in carbon dioxide level, you should also suspect acute exacerbation of COPD. In acute severe asthma, there is no rise in PCO2 level. And in case of acute severe asthma, chest X-ray is usually not helpful until unless patient has developed pneumonia or pneumothorax, which are the trigger factor for asthma. These are basically signs for acute severe asthma. Now coming to the management of the severe asthma, firstly we should provide oxygen to the patients. Short-acting beta agonists are the mainstay of the treatment, which we provide them with nebulizer or inhaler, whichever is feasible. Usually in clinical setting, we provide them with a nebulizer. Also, we can add anticholinergic, that is ipratropium bromide, and rarely, but magnesium sulfate is also given in infusion form, that is 2 gram in NS over 20 minutes is to be given to the patient IV. Also, corticosteroids remain the mainstay. Whenever patient with asthma or COPD, corticosteroids are the mainstay of our treatment. 100 milligram of hydrocortisone is given, or 120 milligrams of methylpenicillin can also be given. If patient is too tachypneic and not maintaining saturation, we can also go for mechanical intubation prophylactically so that we can prevent mortality. Patient usually comes out in clinical settings, patient because of asthma or COPD, if intubated, usually majority comes out of the ventilator support within 1 or 2 days. Am I audible to you all? Kindly reply in chat if I'm audible to you all. Now coming to the endocrinological emergencies, which we will be discussing as hypoglycemia, Myxedema Coma, Thyrotoxic crisis, and acute adrenal insufficiency. Hypoglycemia is the most common medical emergency, Basically, diabetic patients presents to us with hypoglycemia due to improper or poor compliant or over usage of medicines for the OHAs or insulin inappropriately taken. The hypoglycemia is documented by Whipple's triad that are symptoms which are consistent with hypoglycemia, that is patient will have sweating, blackening out, will be a bit of dizzy, and low plasma glucose concentration which is measured by glucose monitor, that is usually less than 70. Relief of symptoms after the plasma glucose level is raised. This is the Whipple's triad for hypoglycemia. The lower limit is 70 milligram per deciliter. These are the causes of hypoglycemia in adults. Drugs are the most common causes. Insulin or insulin secretory drugs that are glimepiride, glycoside, sulfonylureas basically, and non-sulfonylureas. Also alcohol, and when patient is critically ill, that is hepatic or renal failure, or even sepsis, or if there is a hormone deficiency like cortisol deficiency. And the rare ones are insulinoma, which are very rare in clinical presentation. And insulinoma usually does not present alone. We have other endocrinological disorders associated with it. Basically, if a patient is presenting to you with hypoglycemia, you have to rule out the history of diabetes. Also look for the renal functions and the liver function, because usually the patient's renal functions are deranged and patient is continuously taking without any supervision the OHAs, which because of poor clearance causes hypoglycemia. This is the most common practical cause of hypoglycemia in a clinical setting. Apart from being in sepsis or taking alcohol. Now, how to manage hypoglycemia? If patient is conscious, not drowsy, a bit of hypoglycemic, you can give oral sugars to him. Orally he can take and he'll be fine. And if patient is unconscious, not responding and is hypoglycemic, we give them IV, the dextrose containing salines, or IV line is not accessible, we give them iron glucagon injection. 1 milligram glucagon IM is the dose for the adults. Usually, when there is no IV access available to the patient, you can directly use IM glucagon. This is the most common and most easy to manage, but have to be kept as a topmost priority, because if not, neuroglycopenic injury can occur and cause permanent damage to the brain. Now, coming to this emergency, Myxedema Coma, it is still a rare presentation of Myxedema Coma is a rare presentation in casualty, but have to be kept in mind when a patient is drowsy, presents to you a bit of obese, little patient, presents to you with reduced level of consciousness, you have to think of Myxedema Coma with history of hypothyroidism. Usually the patient presents with reduced level of consciousness with seizures and other features of hypothyroidism. Patient can be cold, who is hypothermic, to be kept in mind. And also there is a history of hypothyroidism with very poor compliance. And it's a rule, almost always occurs in elderly patients, not in young hypothyroid patients, and is precipitated by factors such as antidepressant sedators, or patient has developed pneumonia or heart failure or has an attack of MI or GI bleeding. These are the precipitating factor which leads to Myxedema Coma, and it almost always occurs in elderly. Sepsis should also be suspected whenever we're thinking of myxedema coma or vice versa. In sepsis, we can suspect myxedema coma when patient turns out to be unconscious apart from being in septic encephalopathy. It's a rare presentation and presents as loss of consciousness with seizures, so should be kept at lower side of differentials, but should be kept. It's a single IV dose of 500 micrograms of levothyroxine. Mind you, IV dose is to be given at the bolus dose, and if you cannot access IV, you can give it orally. This is the bolus dose. Post that, regular dose of 50 to 100 microgram per day oral dose can be continued to the patient. And other alternative is glurothironine with NG tube 10 to 25 microgram every 12 hours. Patient is hypothermic, so we have to give them external warming and parenteral hydrocortisone should be administered because of impaired adrenal reserve, which is seen in hypothyroidism. Ventilator support can be given if patient is unconscious, there is impaired there is hypoxia or hypoventilation, we can give them ventilator support. Now covering the thyrotoxic crisis, this is just opposite of myxedema coma that is seen in patient of hyperthyroidism. Thyrotoxic crisis per se can be seen in a patient of hypothyroidism, non-hypothyroidism on treatment, going under non-thyroid surgery. That is, patient is over hypothyroidism, patient undergoes any surgery apart from thyroid surgery, can end up into thyrotoxic crisis. Patient will develop fever, delirium, seizures, coma, vomiting, diarrhea. It's a rare entity, but do happen. It is preceded by acute illness like stroke, infection, decay, and surgery. That is, when we are doing partial thyroidectomy, patient can end up into thyrotoxic crisis also. Patient developing thyrotoxic crisis require ICU setting, period intensive monitoring and care, large dose of propylthiouracil, that is 500 to 1000 milligram loading dose is to be given and 250 milligram every 4 hours. It should be given orally or by NG tube or per rectum, either route feasible. Basically, it is given to prevent the conversion of T4 to T3. If propylthiouracil is not available, methanazole is given. That is carbimazole you heard. 30 milligram every 12 hourly. Now next thing is we have to give SSK, that is saturated solution of potassium iodide, 5 drops every 6 hourly. Should be given orally. Propanol should be given to reduce tachycardia and other adrenergic manifestations because of thyrotoxic crisis. Anti-epileptic should also be added because thyrotoxic crisis reduces the threshold for seizures. Glucocorticoid should be given 300 milligram bolus, then 100 milligram every 8 hourly. Antibiotics, if there is infection, which is the precipitating factor, should be given. Now coming to the another emergency, that is acute adrenal insufficiency, adrenal crisis. Basically, this emergency is seen common these days in COVID due to exogenous steroid administration to the patients, and then sudden cessation of steroids, exogenous steroids, lands up the patient into acute renal crisis. That is, patient develops intractable hypotension. Usually, patient with acute renal crisis will present to you with features of acute abdomen. That is, patient presenting to you in casualty with acute abdomen. Medicine people also will have to rule out. That is the acute renal crisis. Acute abdomen is not always a surgery case. We also have to look out the other features and the differentials for acute abdomen. And one of the most common is acute renal crisis. Patient will have abdominal tenderness, nausea, vomiting, and fever. And rarely, not every time, patient can present with coma or stupor or altered level of consciousness as a neurological disorder also. It is also triggered by illness, any surgery or stress. In acute renal insufficiency, 1 liter of saline infusion NS, that is NS is to be given stat daily dose. After that, we have to keep the rate of 1 liter per hour with continuous monitoring. Then we have to give both glucocorticoids and mineralocorticoid replacement as 100 milligram of hydrocortisone. And hydrocortisone with more than 15 milligram of dose also cover mineralocorticoid replacement. If we have stopped hydrocortisone, then we have to give mineralocorticoid replacement. Now coming to the neurological emergencies. Neurological emergencies are very common in medicine emergencies. These are very common presentation to us. Patient presents to you with sudden loss of consciousness. These all topics will be covering. What is syncope? Syncope is transient self-limited loss of consciousness due to acute global impairment of cerebral blood flow. It is rapid, brief duration, and there is spontaneous recovery, and it is a complete recovery. No residual weakness or any sort of weakness is left there, or loss of consciousness or altered level of consciousness. Patient will recover and will be normal within seconds. Basically, this is a difference between seizure and syncope. Patient may present with orthostatic syncope or cardiac syncope, or there can be precipitating factors like patient doing valsalva maneuver or getting up from the bed, or there is an emotional stress. There is basically patient is usually erect when the patient develops syncope and falls. In a seizure patient, it is not necessary. Patient lying down on a bed can also develop seizure. It is not necessary for a person to be erect and falls down because of seizure. And recovery is within seconds. Also, mind you, there is both tonic and clonic movements in seizure and syncope, but in syncope it is never more than 15 seconds. And duration of unconsciousness is only for seconds in syncope, never more than seconds. If a patient is unconscious for more than a minute, you should think of a seizure. Even if the patient has not developed tonic-clonic movements, typical seizure, it can be at the subconvulsive level seizures. As you all know, floating from the mouth, tongue bite are typical features of seizures, but can also be seen in syncope, which is very rare though, but can be seen. Now, we will not be covering seizure in details. We will be discussing the emergency, that is status epilepticus. It refers to continuous seizures or repetitive seizures with impaired consciousness in the interictal period. The duration of seizure activity, which is sufficient to meet the definition, is usually traditionally we specified 15 to 30 minutes, but for general convulsive seizures, if the seizure lasts beyond 5 minutes, we state it as status epilepticus. This is the management of status epilepticus. It is very important clinically for theory exams and for practical purposes. Whenever a patient presents to you with seizures, we give them lorazepam or midazolam IV. Then we start anti-epileptic drugs, phenytoin, valproic acid, or levetiracetam in the given doses. This is impending status or early status, which is duration from 5 to 30 minutes. If the seizures are persistent or there is loss of consciousness for more than 30 minutes even, and there are tonic-clonic movements or any focal movements, then more than 30 minutes will state it as an early refractory status epilepticus, which it is from half an hour to 2 hours. And if the activity further continues for more than 48 hours, it is stated as late refractory status epilepticus. And management for each of them is different. If a patient is in early refractory, we can start infusion of midazolam or propofol as per the given doses. Which, and these patients have to be kept in ICU setting, not in the emergency ward or wards. Patient should be in ICU because patient can need any time mechanical ventilation support because patient is already drowsy or sedated. There is increased secretions from the oral cavity. There are high chances of aspirations. So these patients should never be managed in casualty or in wards. Patients should be shifted to ICU settings because it requires proper care, proper monitoring. Strict vigilant care is required because patient is salvageable in these cases, but due to negligence can end up into mortality. Now another common presentation is stroke. Stroke is basically of two types, either because of cerebral ischemia or there is bleeding. Basically, ischemia is caused by reduction in blood flow, which is lasting more than several seconds. Neurological symptoms manifest within seconds. Patient presents to you with unconsciousness, with weakness in the half side of the body, that is hemiparesis. Similarly, in intracranial hemorrhage, patient will present to you with unconsciousness and hemiparesis or any sort of other weakness depending on the site of bleed or in ischemia depending on the site of infarction happening. So both of the presentation clinically are very similar. It is very difficult to judge without any investigation that it is a bleed or a stroke, ischemic stroke. So that we need a CT scan on urgent basis whenever a patient with hemiparesis or loss of consciousness. You should in casualty get CT, plain CT head immediately to rule out any hemorrhage. It is seen that a patient if develops cerebral ischemia may not show any changes in CT scan initially within 3 hours. But we need to get a CT scan done to rule out hemorrhage. Because in ischemic cases, in ischemic stroke, we can thrombolize the patient, but it is contraindicated in ICH patients. So, whenever a patient with hemiparesis, loss of consciousness, presents to you in casualty, get a CT scan on the priority basis, which will help us to delineate between the both. Now there is another entity, TIA, transient ischemic attack. It is also a very common presentation, but the difference between it and stroke is patient will have all neurological signs, hemiparesis, but will resolve within, it is usually within 1 hour, but which gives a coverage of 24 hours. If symptoms resolve within 24 hours without any evidence of brain infarction on brain imaging, that is, patient is having a TIA. It is a sign that patient has developed any abnormalities in carotids or he is having any embolus in heart which is causing TIA. That is a warning sign for impending stroke, TIA basically. But in TIA, patient will develop weakness which will resolve majority in 1 hour or within 24 hours maximum, and that weakness will be resolved within 24 hours without any evidence on brain imaging. That is stated as TIA. TIA is also very common. One more entity, that is Todd's paresis. Todd's paresis is seen as hemiparesis or weakness of any part of the body post seizure. That is, in post-ictal period, patient will develop weakness mimicking it as stroke or TIA. We have to think of seizure also whenever a patient presents you with hemiparesis. Maybe it is a Todd's paresis. Patient has weakness. Usually Todd's paresis resolves within a day, but maximum can resolve within 7 days also. It can take up to 7 days to resolve. And without any evidence on brain imaging, patient have to be kept as a, we have to look for seizures and stroke as well. These are very common presentation in casualty with very striking differences between stroke, seizure, and TIA. These are the common causes of stroke that are embolic occlusions, that is artery to artery occlusion caused by carotid bifurcation or aortic arch, or cardioembolic, that is there is an embolus of periphery if a patient has infective endocarditis, any vegetation get dislodged, goes into brain, can cause stroke. These all are the common causes. Now, causes of intracranial hemorrhage. Hypertension is very common cause, but before hypertension, aneurysm is also a very common cause. But aneurysm is usually managed by neurosurgery people. They intervene and clip the aneurysm to prevent further bleeding. For our for our field, we have hypertension, coagulopathy, a usage of drugs like cocaine, metformin, or amyloid angiopathy. These are the majority of causes for hemorrhages. I will not be going in detail about the management of stroke and ICH. This is a basically algorithm or flowchart for management of stroke. Whenever a patient presents with stroke, measure his glucose, manage ADCs, airway breathing and circulation, then get the brain imaging done. For in a casualty setup, majority are 85% are ischemic stroke and 15% are hemorrhages. In hemorrhage, you just have to manage the blood pressure. Nothing more than that can be done. If the patient has aneurysm, neurosurgery people will intervene and do the specific management. And if it is because of hypertension, we have to lower the BP. And other causes are to be treated specifically, like for coagulopathy or because of drug usage. And in case of ischemic stroke, patient should be considered for thrombolysis or thrombectomy, but the window period for ischemic stroke thrombolysis is usually 3.5 or 3 to 4.5 hours, not more than that. In a clinical setting, if the patient is presenting within 4 hours, then consider for thrombolysis of ischemic stroke patient. If the patient is presenting after 4.5 hours, then you cannot go for thrombolysis. If you go, then patient can land up into hemorrhage also. It's a very narrow window period for ischemic stroke management, that is thrombolysis. Usually patients present after 4.5 hours because majority patients develop while sleeping without an awareness and they land up into ischemic stroke and presents to after 4.5 hours. Now coming to the anaphylaxis, it is also a very common presentation in a clinical setting. The life-threatening multi-system syndrome with various clinical manifestations. These are the most common etiologies seen in clinical settings. Medications, patients with antibiotics have anaphylactic reactions to antibiotics, NSAIDs, monoclonal antibodies, radiocontrast or any food or insect bite or blood products usage in IgA deficient person or any physical factor with exercise or cold or heat exposure. It is a life-threatening condition though, which has to be managed promptly. They manifest by respiratory distress because of laryngeal edema with intense bronchospasm, often followed by hypotension because of vascular collapse. And there are cutaneous manifestations which can help you, like patient will develop pruritus after intake of any medicine for which he develop anaphylaxis, will have pruritus. He'll complain of itching all of the body post intake of medicine. Even in the case of vaccine, patient develops urticaria or pruritus, then we have to suspect anaphylactic reaction to the vaccine, so that these are the cutaneous manifestations are only helpful to us, which help us to take a prompt action against anaphylaxis. If the patient suddenly develops laryngeal edema, then it is very difficult to manage a patient because you have to directly intubate the patient then and there itself, because patient will land up into respiratory distress which will lead to cardiovascular collapse. And there are few other gastrointestinal manifestation also, like nausea. Patient develops nausea or vomiting to any medication. These manifestation, cutaneous manifestation, are very helpful to us in cases of anaphylaxis. Mild symptoms can be managed by administration of epinephrine, subcutaneous or IM. That is in 1:1000 dilution. Mild symptoms can be managed. Whenever you visit a casualty or medicine ward, just do check the adrenaline injection. It is given in 1:1000 dilution. So if you have to make it in 1:10,000 dilution, you just have to take 1 ml of EDR in 10 ml of NS, then you can directly from 1:10,000 dilution. 2.5 ml of NORAD can be given at 5 to 10 minutes of intervals with volume expanders, that is normal saline should be started, IV access should be done and should be given because patient develops hypertension and require prompt treatment. These are all other management ways, and IV glucocorticoids should be taken for not for acute anaphylactic reaction but for bronchospasm or hypertension or urticaria. They are very effective in managing those. Now, most common presentation for medicine people is acute MI. It is very common and it has to be managed with utmost importance because it is a salvageable condition which majority leads to death. MI is usually, it should be used when there is evidence of myocardial necrosis with ischemia. Very specific definition is for MI is detection of a rise or fall of cardiac biomarker values with at least one of the followings. This whole is a definition that is patient develops symptom of ischemia, new ST elevations or new left bundle branch block. Patient have pathological Q waves, development of pathological Q waves, and there is imaging evidence of loss of viable myocardium that is usually said on echocardiography is RWMA, regional wall motion abnormality. Whenever you see a echo report of a cardiac MI patient, it usually states the wall affected or a location affected, that is inferior wall or septum. There is a term written as RWMA noticed, that is renal wall motion abnormality, which is an evidence of loss of viable myocardium, and identification of intracoronary thrombus by angiography or autopsy. That is, if a patient is to be stated as acute MI, patient should have rise in cardiac biomarker values. That is, CKMB tropi should be raised with any one of the following symptoms or features. That is, patient, if his patient does not have a symptom of ischemia and has any evidence on echocardiography and or has developed changes in in ECG, that is ST elevation or developed left bundle branch block. There is a specific condition or term used for new onset left bundle branch block for MI patient, that is Garbosa criteria. It is a very important condition, that is if patient has developed new onset LVB, it is specific for MI. Usually patients have symptoms for ischemia, but patients with diabetes mellitus may not present to you with specific chest pain, retrosternal chest pain, which are for MI because of autonomic neuropathy. It is a very important thing to be kept in mind as a patient having diabetes mellitus, which is a very risk factor for MI. And usually these patients with chronic history of diabetes mellitus will never present to you with specific symptoms of ischemia because of autonomic neuropathy. So we have to keep all other factors in mind. That is, we have to get that are inguinal equivalence. A term is used, inguinal equivalence. That is, patient will have persistent sweating or have nausea feeling or will have vomiting with no chest pain. We should suspect MI in a diabetic patient for because of autonomic neuropathy. They will not develop the pain. The pain for MI is defined as heavy squeezing and crushing. Retrosternally, not in the left side, it is majority and for retrosternally, which with radiations, you all know left arm up to the left side of the jaw. Now coming to the management of MI, whenever a patient with MI, whenever a patient comes to you with chest pain and casualty, you have got a tropi then and there itself, which is positive with ECG changes, then how you manage these patients? In casualty, prompt treatment to coronary care unit should be done for the MI patient and started oxygen therapy then and there itself. There is a term used as cardiac loading to be given to the patient, that is, give antiplatelet to the patient. If aspirin 300 milligram, clopidogrel 300 milligram, and atorvastatin 80 milligram, then and there in the casualty given to the patient. What more you can do in casualty for managing a MI patient if the hospital is not capable for angioplasty, that is PCI. Hospital is not enabled with PCI facilities, and the time duration for the patient to reach to the hospital with facilities of PCI is more than 90 minutes. Then you can thrombolyze the patient in the casualty then and there itself. Thrombolytic agents are streptokinase. These agents are to be given keeping in mind blood pressure of a patient. If blood pressure is more than 180 or less than 90, systolic blood pressure is more than 180 or less than 90, you should cautiously use these agents. Firstly, manage the blood pressure thing, that is start a inotropic support if blood pressure is less than 90. Start inotropic support and then thrombolyze the patient. If blood pressure, systolic blood pressure is more than 180, lower down the BP and then start thrombolytic agent, streptokinase, reticlase, LTplase to be given to the patient. Whichever is available in casualty, give it and save the life. For thrombolysis to be successful, imagine if the patient, you're working in a primary health center with no facilities available nearby, you have to manage the patient. How will you assess have you successfully thrombolized the patient or not? Whenever you get a patient with ST elevation MI2, watch the ST elevation before thrombolysis, then start thrombolysis. After 45 minutes, check for the after thrombolysis and waiting for 45 minutes post that, check for the ECG changes. If ST elevation has reduced by more than 50%, then we have successfully thrombolized the patient. Also, patient do present with symptoms of ischemia with raised cardiac markers but no changes in ECG. That term of no NSCMI, non-ST elevation MI patients. For them, management is same, but prefer PCI in those patients instead of thrombolysis. Or you can thrombolyze the patient, but you can only monitor the patient, not you cannot compare the ECG. Also, give the anti-anginal agents like sorbitol to the patient. And also to be kept in mind while giving anti-anginal, look for BP first. If BP is on the lower side, hold anti-anginal agents. Also, very commonly used beta-adrenergic blocker. Beta blockers are used, but always keep in mind when a patient with MI presents to you, if he is in failure, cardiac failure, never ever give beta blockers to them. Give rest of the therapy remains the same, just that beta blockers has to be avoided if the patient is in failure. Now coming to sudden cardiac arrest. Usually patient presents to you with cardiovascular collapse or cardiac arrest. What is cardiovascular collapse? It is sudden loss of effective blood flow due to cardiac or peripheral vascular factors that may reverse spontaneously. If collapse does not recover spontaneously, reverse spontaneously, then the patients land up into cardiac arrest. That is abrupt cessation of cardiac mechanical function, which is reversible by prompt intervention, but if not intervened, will lead to death. And sudden cardiac death is sudden irreversible cessation of all biological functions. You cannot do anything about sudden cardiac death. What we can do is manage cardiovascular collapse, manage cardiac arrest, so that you can prevent sudden cardiac death. Now it is individual collapses suddenly used to be managed in 5 ways, like initial evaluation, what is the cause for the collapse, and give basic life support if there is cardiac arrest, and excess defibrillation wherever, whenever available. For imagine, for a situation like if a patient collapses in mall, what you have to do is evaluate the patient, what has happened to the patient, call for defibrillation. Usually these days norms are as such that there should be a defibrillator in a public place setup, that is in mall. If it ever happens in hospital, then you just have to press the code blue button in wards. Whenever you in wards see a patient collapsing in front of you, press code blue. The whole team will arrive at the situation and manage the patient. It is that confirm the that sudden collapse with loss of consciousness is due to cardiac arrest. Look for the observation, respiratory movements, skin color, presence or absence of pulses in carotid or femoral. What should be your initial response? Clear the airway, prevent tongue fall, which will, if happens, will cause respiratory arrest and cause lead to cardiac arrest or cardiac death. Tilt the head backwards and lift the chin so that oropharynx can be explored and can be seen for clear airway. BLS to be given, that is provide CPR, and while providing BLS, as you all know, call for medical emergency help or press code blue if in hospital. If it in public place, call for ambulance and provide CPR to the patient so that you can provide the perfusion to the patient until unless the patient is admitted somewhere. These are the basically two things which usually patients present with cardiovascular collapse. Patient may in bradycardia or can be tachycardic. That is, patient is having ventricular fibrillation or pulseless VTs. Or patient can present you with asystole or bradyarrhythmia. In case of bradyarrhythmia or asystole with pulseless electrical activities, then they start CPR. Whenever you see a collapsed patient, firstly see the carotid, feel the carotids. You feel there is bradycardia or asystole, immediately start CPR without wasting any time. Start CPR. If feasible, intubate the patient, access IV lines. Then after managing the patient with CPR, intubating the patient, look for the treatable causes. What could be the possible reason the patient landed up into bradycardia or asystole? Look for the possible causes and treat accordingly. Then initiate ADR, give ADR to the patient, give atopic to the patient, or soda bicarb. These are all the basically causes patient developing hyperkalemia or developing pulmonary embolism or massive acute MI or hypovolemia or hypoxia or temporal. Any of these possibility can be there in an admitted patient due to any and should be managed promptly if in clinical setting. These all things can be managed only in clinical setting, not in a public place. So whenever you see a patient, you have to give basic life support outside the hospital and shift the patient to the hospital so that he can get advanced cardiac life support, that is ACLS. VF or pulseless VTs. These are to be managed given if the patient is in VT or VF, defibrillate the patient then and there and start if it is within the 5 minutes of onset. If the patient has developed VT within 5 minutes of onset, suddenly defibrillate. If it is more than 5 minutes, give CPR for 60 to 90 seconds before defibrillating the patient. This is to be kept in mind whenever you posted in ICU. You see the patient have developed VT in front of you, defibrillate the patient then and there itself. And if you see it as the patient has developed VT for more than 5 minutes, start CPR only when the patient has collapsed, not that the patient is hemodynamically stable. Start CPR and defibrillate the patient. This is the basically whole flow chart of the management of the VT or VF. Has been taken from Harrison. You can see later on from there. Four components post cardiac arrest we have to think of: brain injury, myocardial dysfunction, systemic ischemia, reperfusion responses, and control of persistent precipitating factor. These four things which have to be kept in mind. We have to prevent brain injury, look for myocardial dysfunction, and we have to control the precipitating factor. That is, in case of hypokalemia, hyperkalemia, hypoxia, tamponade, pneumothorax, which are the causes of that is for asystole. We have to manage that promptly so that we can prevent further collapse. The therapeutic goal is to maintain stable electrical, hemodynamic, and central nervous system status. For patient with cardiac arrest determined to be due to a treatable transient ischemic mechanism, particularly with higher ejection fractions, catheter interventional, surgical, or pharmacological anti-ischemic therapy is generally acceptable for long-term management. But for the patient who has survived cardiac arrest due to other categories of the disease, such as hypertrophic cardiomyopathy or dilated cardiomyopathies, various inherited disorders like right ventricular dysplasia or low QT syndrome, Bragg syndrome, these all patients should be considered for ICDs. ICDs should be placed in these patients so as to prevent further cardiac arrest. These all hypertrophic, DCMP or right ventricular dysplasia can recurrently lead to VD or VF in a patient. So as to prevent these manifestations, we should consider for ICD placement. Whole detail is given regarding the indication for ICD placement in Harrison, which you can take a look. Now coming to the most common condition known as shock. I'll not be covering the shock in whole detail as I'm covering the specific part. It is a clinical syndrome that results from inadequate tissue perfusion. Shock is accompanied by hypotension, that is mean arterial pressure less than 60 millimeters of mercury. In previously normotensive persons, it has to be kept in mind a person who is previously normotensive and has mean arterial pressure less than 60 is clinically in shock. Usually patients with dilated cardiomyopathies will have a lower normal range of blood pressure. Then we do not state those persons as normotensive. That is why it is very important to state normotensive person developing mean arterial pressure less than 60 is shock. Management is whenever patient develops shock, always make imagine you're in ICU or wards having taking blood pressure in your internship. You see the blood pressure, systolic blood pressure is less than 90. The first thing is to be managed is if the patient is propped up or seated up, ask the patient to lie supine. Patient should be head low position so that there is no lack of perfusion to the brain. Then manage regarding the respiration, give IV fluids, then and there itself manage acid-base balance if the patient is acidosis or alkalosis, manage according to that. And if patient is in ward, shift the patient directly to ICU if the patient has developed shock. Continuous assessment is required in a case of shock. Arterial pressure through indwelling line, pulse and respiratory rate should be monitored continuously. Foley catheter should be inserted to follow urine flow. It is very important to measure. To state a person in shock, there should be oliguria. If a person is hypotensive with no oliguria, then patient is not in shock. If person is hypotensive with oliguria, that is 0.5 milligram, 0.5 ml per kg of urine out, less than 0.5 ml per kg in whole day, the patient urine output with hypotension, then you can state that person is in shock. If urine output is adequate with hypotension, that will state the person is in hypotension, not in shock. This is an algorithm for resuscitation of patients in shock, hypertension, and or tachycardia. Always look for airway control, assure ventilation, augment circulation by providing IV crystalloids. If patient is unstable, that is heart rate is more than 120, systolic blood pressure is less than 90, look for CVP, central venous pressure. If it is less than 15, go for administering the crystalloids. Then if CVP is more than 15, then you cannot provide crystalloids to the patient until and unless you assess the cardiac function, cardiac dysfunction, or the patient is in tempo heart. You should always access the line and look for CVP before administering fluids in a case of shock. If it is more than 15, you cannot give crystalloids to the patient. Go for echo and then treat the appropriate cause. Insert arterial line, then look for cardiac index and capillary wedge pressure and manage according to that. If cardiac wedge pressure is more than 20 and cardiac index is less than 3.5, start the inotrope. Do not give crystalloids. And opposite to it, if cardiac wedge pressure is less than 15, give crystalloids. So managing shock, firstly, look for the cause. What is the cause leading, which has led to patient to the shock? And measure CVP, and then arterial catheter should be inserted and look for capillary wedge pressure. If not feasible arterial line, go for central line and then measure CVP and administer the fluid accordingly. This is the management of cardiogenic shock, specific for cardiogenic shock. If patient is hypovolemic, go for fluids, blood transfusion. Whatever be the cause for hypovolemia. If patient has low output cardiogenic shock, always look for blood pressure. If systolic BP is more than 100, go for nitroglycerin. So as to manage cardiac shock. If systolic BP is between 70 to 100, go for dobutamine. If less than 100 and with signs and symptoms of shock, go for NORAD. Ideally, NORAD is the inotrope of choice in cardiogenic shock. Dobutamine and dopamine are arrhythmogenic, so we have to be always careful while using the inotrope. NORAD is the inotrope of choice in managing cardiogenic shock. Bradycardia and tachycardia is to be managed as discussed previously by defibrillating or using adequate medicines for them. Now coming to poisoning. Most common poisoning which comes to us in casualty is OPC poisoning and snake bite. Snake bite is not common in Delhi per se, but in outskirts of Delhi or whenever you post it in PHC or rural areas, snake bites are very common. These two poisoning are very common. Another common poisoning is sulfas poisoning. But sulfas poisoning I'm not discussing here because there is no proper clear management. Patient taking ingesting sulfurs, majority 99% patient does not survive at all. So I'll not be discussing sulfas poisoning, I'll be discussing OPC and snake bite. Organophosphate poisoning, usually patient comes to the history of that person has ingested the uh, insect disinfectant products has been ingested by the patient, which are usually OPCs. These are the compounds which are seen in the disinfectant, like using all out or hit. These patients usually inhale or ingest these compounds and come to us. These are all the compounds: methylparathione or endosulfan, malathion. In general, after OP exposure, patient will develop symptoms which are very common are that is pneumonic ileal sludge, salivation, lacrimation, urination, defecation, gastric cramps, emesis. That is, whenever a patient with unknown substance ingestion comes to you, if you see symptoms like patient is sweating, profusely drenched in sweats, with oral cavities filled with secretions, and patient pants are soiled in urination or he is defecated with persistent vomiting, always think for OPC. Clinically, whenever you go in casualty and see these patients, you will see these symptoms very common in these patients. And other nicotinic effects are like motor and sympathetic can result in fasciculations, muscle weakness, tachycardia, or hypertension. When one of the retrospective studies for opioid poisoning, muscarinic symptoms and signs were the most frequent, that is, it was seen 84%, followed by CNS and nicotinic 17%. These are the muscarinic symptoms: salivation, lacrimation, urination, defecation, slug symptoms. This is a table depicting very important table for OPC. That is, what are the manifestation, acute manifestation, delayed manifestation, and late manifestation. Usually, acute manifestations are not of a worrisome issue. These can be managed with antidotes. But delayed manifestation, that is intermediate syndrome, it is very common. Commonly seen in patients admitted to us with OPC substance intake. I'll be discussing in detail regarding intermediate syndrome, and these are the acute, delayed, and late manifestation, which you can look. Whenever patient with poisoning comes, except for corrosive poisoning, always go for gastric lavage. In OPC poisoning also, go for gastric lavage. If charcoal tablets are available, put charcoal tablets via RT into the stomach. What are the antidotes? Atropine and oxymes. Atropine is to be given till atroponization. What are the signs of atroponization? Clinically, you will see there should be dry skin, dilated pupils, person should be tachycardic, and person should develop fever. These are the signs of atroponization. Atropine should be given bolus until when patient patient is atroponized. How will you look? Look for axilla, whether it is dry or not. Look for fever, look for pulse rate more than 100. It should be more than 100. If you're giving atropine and still heart rate is not more than 100, then you need to dose more atropine so that person is atroponized. Then another thing are oxymes. Oxymes are used for nicotinic effects to neutralize the nicotinic effects. Common entity uses injection PAM, which you will see whenever you go to casualty or ICU, you can look for injection PAM. Basically, oxymes are nucleophilic agents that leave covalently the covalent bond between OP of the OP acetylcholinesterase conjugate, which release acetylcholinesterase. Manage other complications because of OPC poisoning, that are pulmonary edema or respiratory paralysis. Intubate the patient. It is the late manifestation though, but if needed, intubate the patient. What is intermediate syndrome? It is best described as delayed manifestation. It is characterized by paralysis of proximal limb muscles, neck flexors, motor cranial nerves, and respiratory muscles. 24 to 96 hours after poisonings, after the cholinergic phase has settled down. And this weakness usually lasts up to 18 days. On electromyographic studies, neuromuscular junctional defect has been demonstrated in intermediate syndrome. It has been reported 114 hours after poisoning also. One of the case study has shown that after 114 hours also, usually it presents after 24 to 90, within 24 to 96 hours, but it has been reported even after 5 days, 5 to 6 days. This is the reason for delayed symptom onset in OP poisoning, because the lipophilic and persistent fat stores, redistribution and reinhibition of cholinesterase may have delayed symptom onset. Coma is seen in 17 to 29% of the patient and can last for hours to days. Also, OP poisoning can also present as brainstem stroke. However, some patients manifest altered consciousness or coma days after poisoning, particularly after a period of normal consciousness. If the patient is with OPC normal for days, then suddenly develop coma. This clinical entity is termed as delayed organophosphate or CNS intermediate. Coma with absent brainstem reflexes or encephalopathy has been reported even after 4 days of normal conscious and spontaneously resolved after another 4 days. Now coming to the last topic, snake poisoning. In India, 4 species are responsible for 99% of venomous bites. They are called big fours. They are spectacled cobra, Russell viper, common crate, and sword-scaled viper. This is basically a generalized classification for snake bites: venomous, non-venomous, venomous, neurotoxic, hemotoxic, or myotoxic. Neurotoxics are cobras and kraits, and hemotoxic are Russell viper and pure hemotoxic. Both neurotoxic and hemotoxic have different management. Whenever a patient with snake bite presents to you, provide them first aid. Usually it is a mnemonic is do right, which consists of reassure the patient, ask the patient not to panic. Once the panic sets in, we will always lose a patient after a snake bite. Ask the patient to not to panic and reach to a hospital directly. Immobilize the patient. Immobilize the brittle limb in the same way as a fractured limb. Never use bandage or never apply any tourniquet to in front of the bite. Never ever do that. Then go to hospital immediately. More traditional remedies have been beneficial in cases of snake bite, and tell the doctor of any progression or new symptoms after the snake bite. There is an anti-snake venom for all of these, all big fours. Single antidote is available, that is anti-snake venom. It is multivalent, that it contains all covers antidote for every snake bite in India. In case of hemotoxic bite, 100 ml, that is 10 vials of ABS in 500 ml NS is to win over 4 to 6 hours, preceded by 100 milligram of hydrocortisone. And in case of neurotoxic bite, firstly we need in both cases, hemotoxic and neurotoxic, intradermal test of anti-snake venom is must. Post that, we give 10 ml or 10 vials of ABS in 500 ml NS with preceded by hydrocor. In case of neurotoxic, give atropine with myostatin. Combination is to be given to the patient, and we can give anti-snake venom till the patient is relieved. This is not a single dose, that is 100 ml and 500 ml NS for 4 to 6 hours. If the patient is not relieved, repeat it again. Repeat it until and unless patient is relieved. And rest complication developing rhabdomyolysis or acute renal failure should be managed as per the onset of the complications. Thanks. That will be all from today. Can you tell me regarding the tennis? So I'll finish up the class now. Yeah, I'll finish the lecture now. Any doubts or any questions? Let's see questions.